thank you for the opportunity to discuss about my presentation. This was my original research, and the interest in this research was primarily developed even during my residency when I was doing psychiatric residency. And the reason was that the sleep disorders are very common, and there are many sleep symptoms which are even the diagnostic criteria for several of the psychiatric disorders. Next slide, please. So during this research, what exactly I wanted to know that is there any impact of treating sleep disorders in the outcome of the psychiatric disorders? So what I did is, this was a retrospective chart review study. This was done during my sleep fellowship. What I did is I reviewed 187 charts at VA Medical Center in Milwaukee, and that was from October 2007 to December 2007. All the charts were reviewed at the point of this period, 3 months, and all the charts were reviewed 6 months, 12 months, and 24 months. The first information was that the most common diagnosis was obstructive sleep apnea. And out of 187 charts, the charts were removed in the study which were not followed during this period. And there were 10 patients who were excluded because of the report of death. Those deaths were not because of the suicide. They were primarily some medical reason, congestive heart failure, mitral infarction, or a stroke, something like that. So the point I'm trying to make is that only the charts were included in this study who had a confirmed sleep disorder diagnosis, and outcomes were evaluated for 6 months, 12 months, and 24 months. So during this study, what I found is that out of all the exclusion, there were 117 charts were included. Out of 117, 97.6% were the male, because this was a veteran patient population, so more of the males. And out of 117 charts, 54 charts who had comorbid psychiatric and sleep disorders. And this data is, I didn't present all the other information from the previous sleep studies. It supports that almost 45 to 50% of the patients who had a psychiatric disorder, they have a comorbid sleep disorders. And most of the patient population was in the range of 41 to 60 and 60 to 80 years. Next slide, please. So, if I look at the response to the psychiatric conditions after the treatment was started, this chart shows at the time of the baseline, 6 months, 12 months, and 24 months. To start this study, what I did is that we selected 5 different parameters to evaluate at these 3 different times, or I would say the 4 different times, baseline, 6 months, 12 months, and 24 months. We rated all the categories in 5 categories: marked improvement, 2+, partial improvement, +1, no improvement, or no change is 0. At the same time, worsening, partial worsening, -1, marked worsening, -2. And what I concluded at the end is that the treatment of comorbid sleep disorders, I'm still here mentioning obstructive sleep apnea because most of the patients, they had obstructive sleep apnea as the prime diagnosis, was associated with a significant improvement in the psychiatric disorders. Psychiatric disorder did not affect the compliance with the sleep disorder treatment. No significant improvement observed for the specific psychiatric disorder. After I look at all the data, what I found that most of the patients, they had a multiple psychiatric diagnosis. So if I analyzed on a Wilcoxon signed rank, what I found is that the N for a specific psychiatric disorder was very, very low. That might have lost the power of the study, and that might have affected significant improvement in a specific sleep disorder. And at the end, what I concluded that there is a strong need for a prospective study, because this was a retrospective study. This study did have some limitations because all the charts were reviewed by me, so there might be some personal bias. And because the Likert scale was used, and Likert scale does have own limitation of the central tendency, so there were other limitations too. Thank you very much.